Okay, so to report a service or treatment to insurance, but a provider use claims. Okay, so claims have a life cycle. First is pre-submission. Pre-submission is basically when you are creating a file or when you are creating a report, you do a rough check of the report, like everything is fine, all the data is in place. Similarly, is for claim pre-submission. Like before submitting claim, provider do a rough check of claim, provider or billing entity or whoever do a rough check of claim, like claim has all the required information, claim has all the information correct, and there is nothing that can cause claim to be denied. Okay, the next step is submission. What happens, like once everything is done, once claim pass the pre-submission life cycle, the claim is submitted to insurance. The claim is submitted to insurance using two methods. It's either electronic or on paper. Electronic claims are basically known as 837 file, which will come later. Okay. Paper claims are known as CMS 1500 and UB04, based on where the treatment was given and what type of treatment was given. So if it's an hospital treatment, then on paper we submit UB04 and electronically we submit 837I. If it's an office, provider office or outpatient treatment, then we submit CMS 1500 or 837 professional or 837P. Okay, we submit the claim to insurance payer. Once payer receives the claim moves to claim adjudication. In claim adjudication, payer reviews the claim information, all the information, then payer reviews whether the patient in question have a proper coverage, all the services that are provided to patient are covered by insurance plan or not, whether provider is eligible to submit claims for this payer to this payer or not. And based on all these parameters, payer decide what payment they have to make to provider. Okay, the next is then it's payment. Payer usually send the payment into provider's account, and they send an 835 file. 835 is basically electronic remittance advice. You can say in layman terms, 835 is the invoice of the services. Okay, okay. So once payment is received, there is one more cycle of post payment, or we can say in healthcare terms, we know that as account receivables. Okay, so let's say there is a patient, he received three services. The claim is submitted to Medicare payer. Medicare paid for two services. Medicare denied one service because they said that it is not covered. This service is not covered under patient insurance plan. So that claim, that one service will go into account receivable cycle. Account receivable cycle first is post payment. In post payment, provider review the payment, what the payment received, what is the balance amount, what is the balance pending amount, and what needs to be done next. Whether this needs to be billed to patient, whether this needs to be billed to next responsible party, or they have to raise a appeal because it's an error from payer side. Okay. Based on that, whether it's appeal or what, the next is follow up and reconciliation. Okay, provider office will follow up with payer or patient for remaining payment. And once the payment is received, they will reconcile their records or like making balance zero. Okay, and see the claim life cycle again can vary payer by payer. There are multiple factors involved. Like few examples are for Medicare. Let's say for Medicare, what Medicares do sometimes, like if you build three services, two services are covered by Medicare, one service is not covered, and in Medicare system, you have the patient have another insurance, so Medicare directly submit your remaining services to next payer. You do not have to do that. Like you do not have to do post payment for our follow up or reconciliation. That will be done by next payer. That will be taken care by next payer. Similarly, for Medicaid, Medicaid have a rule that Medicaid will always be the last responsible party for the patient. For example, if patient have five insurances on file, then patient claim can be submitted to Medicaid only if claim is denied by first four payers. Okay. Also, Medicare rules. I don't think like Medicare have rule like the patient must be more than of age more than 65 years or under ESRD condition for more than 2 years. Then only you can then only patient becomes eligible for Medicare. Or patient is railroad employee, then they are eligible for railroad Medicare. Similarly, for Medicaid is either patient is below poverty line or patient is under any managed care plan. Then they become eligible for Medicaid. Okay. So any questions till now?
Team, do you guys know what is Medicare and Medicaid?
And and what are ESRD diseases? What is ESRD?
Yes.
Right. So basically, ESRD is something where there is no treatment. The patient has to live on. There is no permanent treatment for that disease. Patient has to live on temporary treatments for his life. Okay.
Yeah. With the Abhinav's Medicare and Medicaid, I have one question to the team. So, Medicare and Medicaid plans are commercial plans? To the team, I'm just asking. And what about Medicaid? Medicare?
Both of them are federal plans.
Yeah, both are federal, different from the commercial. Yep. Yeah, Abhinav, please.
I was going to that only. So when we say vary on pair depending on payer, so multiple in US there are three type of pairs: federally managed by federal government, managed by state government, and commercial. Okay, so managed by federal government plans are Railroad Medicare, Medicare, Veteran Affairs, Medicaid. Okay, managed by state government plans are Blue Cross Blue Shield, then Tricare, and there are some specific state plans that like I can't recall all the names. And the third one is commercial. Commercial. Commercials are basically like your United Healthcare, Aetna, Cigna, all those payers. So the difference between federal payers and state managed and commercials are for federals you do not have to make any premium payment. There will be some copay. But that's all. And even there are specifications like again Medicare is for patients greater than 65 or ESRD. Medicaid is for patients below poverty line or under managed care. Veteran Affairs is obviously for Army veterans, and Railroad Medicare is for railroad employees. Similarly, state government managed plans. State government managed plans are basically like the plans that is for state government employees. And also there is an option for normal people to pay the premium and purchase the services of that plan. The biggest state managed plan is BCBS, Blue Cross Blue Shield. Okay, and the next is commercials. Commercials like anyone can purchase. If you can afford, you can purchase commercials. Okay. And so, do you want me to go into details of managed care or PPOs, HMOs?
Yeah, I think that will be mm, too much now for them in terms of healthcare. I think the agenda that we have set, right? The
Yeah,
healthcare basics claim and then going with the EDI, that will be good. But if they have any questions regarding that, they can bring it to the forum and we can just clarify their questions.
sure. Now let's go to EDI. First thing, why EDI? Why we have to use EDI? Again, it's a secure, it's secure. It's in a standard format that everyone have to use. Like if it's, like when we talk about databases, when we talk about code, we not every organization or entity use the same format, right? But when we talk about EDI, be it any entity, be it government, be it federal, be it state government, be it a commercial, be it a large scale hospital or a small scale provider or like a 1-2 patient clinic, they all use the same standard set. They have to follow. And the reason why they are using same standard set is, see, basically in USA there are 11,000 insurance plans, more than 11,000 insurance plans. And if every plan comes with their own standard, like, okay, no, I will follow this standard. Send me claim on Excel, send me claim in CSV, send me claim on Word file, or send me a database file or anything. Being a provider or hospital, being a service provider, it will be hell for provider offices or hospitals to manage the claim submission. Okay, this is the reason CMS and AMA came up with a standard format of EDI, X12 EDI. Okay, so every entity follow the same format, and the EDI files that we will be going in details here are 270. 270 is used for when we have to check for whether a patient have active coverage with insurance or not. We submit them 270 file. And against that 270 file, payer respond us with 271 file. So we will be covering 270 and 271. Next is 837 I and P and 835. So 837I we use for claim submission when service providing entity is of type hospital, or the services are rendered at an inpatient or skilled nursing facility. Okay, the next is 837P or 837 professional. We use 837P whenever the service is rendered at a doctor office or services are of outpatient type. Okay, and the next is against the response of 837 INP, payers submit us 835 files. Okay. So, any questions till now? Any questions for EDI files?
Abhinav, can you explain the 271 and 835 again?
Yeah. So, see, 271 is. Let me add a new slide here. Okay, request.
271.
Yeah. Then I have response.
835.
Yeah. So request is my 270. 270 is my eligibility benefit. Eligibility and benefit inquiry. And against 271 we receive 271. Sorry, against 270 we receive 271. That is eligibility and benefit response. Okay. Similarly, 837I. This is used for claim submission for IP, SNF, episodic services. Okay. And response for 837 is 835. Response for 837 I5. Similarly, 837P, claim submission for OP, professional, services. Response for 837P is 835 only. There is like 835 is the claim response file. Okay.
Yeah, the payment of the claim.
Payment.
Payment
Yeah, payment.
description. Yeah.
Payment description. Okay.
Explanation of
Now,
payment.
yeah, see. Now 270 is again eligibility and benefit inquiry. When we submit the 270 file, we submit the patient name, patient information, demographics, which include patient name, patient insurance information, patient insurance subscriber information, and we submit the provider information, who's the provider providing the services, and when the provider is providing service and what type of services they are providing. Okay, so say I have here, wait. So if I'm submitting 270, information that I will have: patient demographics, patient insurance, insurance subscriber information, provider information, and date of service. Again, not all insurance payers ask for provider information or date of service. Okay, but there are some like Medicare and BCBS, these type of insurances, they ask for provider information, date of service. Okay, and the next against 270, we receive 271. 271 have patient in demographic, all this information. Then they have coverage information, whether patient have active coverage or not. It's why or no, not why or no, there are codes. But then they have coverage type information. Okay. If patient have active coverage. So say like one more thing, if we want to be more precise, we submit type of service also in 270 file. Like if we want to get information of specific type of service. Okay, so on 271, the insurance will respond you with patient demographics, patient insurance, is insurance subscriber information, coverage information, whether patient have active coverage or not. If patient have active coverage, they will inform you with all the type of coverage, all the type of services that are covered. Type of services basically like say you can say professional services, surgery, dentistry, orthopedic, ophthalmology, all those type of services that are covered in the insurance, patient insurance plan. Okay. Similarly, when we say 837, under 837, we will submit patient demographics, patient insurance subscriber information, and we will submit provider demographics information for billing provider. Okay. Next is we will submit provider information, a rendering provider, and services given as CPT and ICD code. Okay. Now the question here is I hope you guys will ask. I was hoping you will ask, what's the difference between billing provider and rendering provider? Can anyone tell me?
Billing provider is a hospital kind of thing. Rendering provider is a service who provided that, for example, doctor kind of.
Okay. Can a rendering provider be a billing provider?
Yes, he can be. Sometimes when he's having a own facility. So he's running a clinic kind of thing.
Yes. Yes. Okay, and in 835 we received patient again. This thing is common. We will not receive patient insurance information at 835 because we know that this is what we are getting. We will receive complete patient demographic. Services rendered, sorry, provider information. Services given, services rendered, and payment made. Payment and adjustments. And can anyone tell me difference between payment and adjustment?
Some claims we have already paid excess amount. So the provider is again billing for the some other service for the patient. So in those cases, you can adjust the difference amount there.
Yeah, that's one right. That's one thing, but there is a broader of like there is a broader discipline of payment and adjustment. Okay, no worries. So see what happens when we bill. There is a fee schedule. I hope you guys know about the fee schedule, CMS fee schedule.
Look, I think Avinav, I'm not sure. Maybe they are not having that much
Okay,
of details. I'm not sure.
that's
So, yeah,
absolutely. See, I just want to know whether they know. If
correct.
they know, that's fine. If they don't know, then I can go in details. Go in detail.
Yeah.
Okay.
So,
So
just want to check with you all that do you have any knowledge in the fee schedule and also claim payment adjustment? So don't think about always like US healthcare. Whatever Avinav is mentioning here, these are common in all health insurance policy, even in India also. These are not different than US healthcare. So you can, if you know the Indian or any health policy in India, if you go to the doctor and then you submit a claim, whatever things are going on, the same thing is going on in US healthcare also. Only the terms, the codes, these are different, but the basic logic, idea, all are same. So if you know that, you can answer here also. If you know what is payment means, insurance company is paying to the provider or patient based on the contract. What is adjustment? The amount that insurance company is not paying because of out of contract, or the contract says $100 and they are billing $120, the $20 they will not pay, or any copay, coins, any other adjustment, all these will be mentioned in the 835 as the explanation of payment, where the amount got adjusted, what is the allowed amount and paid, what is the covered amount, what is non-covered amount, non-covered amount, all are adjustments. So the same thing, if you file one claim to the insurance company and the insurance company in India, they're paying, they will not pay entirely, right? You file for 150, suppose 1,50,000, they will not pay 1,50,000. They will check what is the contract, what is the covered charges for this particular service. Hospital cannot bill 1,50,000. So the same concept what Avinav is telling. So if you know the Indian style also, you can answer, and that will be the correct answer for US healthcare also. Okay, am I right, Avinav?
absolutely so.
Yeah, thank you.
Okay. Oh, sure, guys. No worries. It's like even that's fine. Absolutely fine. If you don't know the answer, that's absolutely fine. But please ask questions. The thing is, fee schedule is like every year CMS and the governing bodies of healthcare, CMS, AMA, and all decides that what is the max charge, what is the approx, sorry, not max, approx charge provider can ask for, what is the maximum amount provider can get for a sorry, not maximum. What is the approximate amount provider can receive for a service rendered? Okay. So let's say there is a service, there is a CPT code 99213. 99213 is used for office visit, new patient office visit. So whenever a patient is visiting first time in the provider office for a general checkup, the provider will bill CPT code 99213. Okay, for 99213, the CMS has decided the approx payment can be $25. Okay, but at time of billing, provider billed it like to say $100. Okay, for 99213. Now, insurance is not going to pay that $100 because they are not obliged to pay you $100. What they are obliged to pay is the fees, is the payment defined by CMS. Okay, decided by CMS. So what insurance will do? First, insurance will from $100, they will just simply remove $75 as contractual obligation. Okay, it's a contractual obligation between CMS and all the providers and all. Then insurance payer will check what's the contract with the what contract they have with the provider. Okay, let's say they have a contract with provider that okay, for all office visits we will pay you $15. Okay, nothing more than that. So what they will do, the remaining was $25, so they will simply remove $15 also from that claim, from that payment, and pay $15. Sorry, they will simply remove remaining $10 from the claim and pay $15 to provider. So provider billed $100, they receive $15 and rest $85. $85. Now again, here is a catch. In India, like if I billed insurance 1.5 lakhs, they paid 80 lakhs, then provider or hospital can take that remaining 70,000 from me, from patient. Okay, but in USA, if a payment is denied as a contractual obligation, you cannot bill patient for that claim amount. You cannot bill. Like you can of course bill, but a patient can complain. Patient is not obliged to pay that, and patient can complain against you, which will cause in loss of license and all if there are multiple repeated instances like this. Okay. Now the second type of adjustment is like let's say payer received $100. A payer received a charge of $100. Payer checked in their system, and the provider, either provider is not contracted with them or the patient is not on file. Patient is not contracted with them. The claim was submitted to error. Then payer will not do any contractual obligations or anything. Payer will simply deny the whole claim. The whole $100 will be adjusted, will be set at adjustment to provider, whole $100. Okay. So the difference between contractual obligation adjustment and payment is like payment is what payer is paying to insurance. Then adjustment is what payer is refusing. What part, sorry, not what payer is refusing, what part of charge amount payer is refusing. Okay. And the next term is denial. Denial is something when payer refuses complete payment at complete, when payer refuses the complete claim, like it's not their responsibility. Okay, so the again difference between payment, adjustment, denial is payment is what payer is paying to the provider. Adjustment is what part of charge amount, what portion of charge amount payer refused to pay provider due to some contracts, due to any reason. And denial is if payer refuse the complete claim, that this is not their responsibility. Okay, so any questions on payment, adjustment, and denial? CO 45 is
Yes,
contractual obligation.
very good.
Yeah,
Yep,
CO
yep,
45
you're
is
right.
contractual obligation. Yeah, so correct in see in 99.9% of cases for corrected claim it's a denial. There was a denial received.
Okay, any
Okay,
other
guys. So
question to Abhinav?
yeah, let's use last 10 minutes for questions and answer questions because we talked about claim life cycle. We talked about a few EDI files. So let's use last few minutes for question and answers. Anyone, please don't hesitate to ask question. Okay, and this is for everyone. Mhm. Yeah. See, that we will go when we talk about 837I in detail. We will go for revenue codes, we will go CPD codes, those things, value codes, occurrence, we will cover then. But yeah, revenue codes are used for inpatient claim, inpatient and episodic claims. And can anyone tell me what's the difference between inpatient and episodic services for more than 24 hours?
Yeah, more than
For, yeah. And what's episodic? Right, right. Okay, yes, right. But now, if you see the episodic answer is partially correct. But here, if you see here, I have mentioned that for episodic services, I use 837I. For outpatient, I use 837P. So why so? Why I use episode 837I for episodic?
Is for
From a
institution side.
No, episodics
episodic,
are
I
basically
believe,
outpatient treatments.
yeah, from episodic, Abhinav, I believe that there are many like customers who claim like for the day charges or something kind of thing, like which for a particular time constraint.
Uh, yeah, partially correct. Partially correct. So basically episodic is when patient has to go in in a whole treatment cycle, like for dialysis. For example, one example, dialysis, the ESRD. Dialysis, dialysis treatment is given in cycles. So if the patient is on hemodialysis, then there will be how much? 13 treatments in a month. If patient is on peritoneal dialysis, then it will be like four treatments in a month, and then the catheter, the dialysis catheter, all will be installed inside patient's body. If patient is on home hemodialysis, then there will be 30 treatments a month. Okay. Similarly for behavioral health, it's not just you patient went to provider for one and everything is done. It has to be done in a cycle. There will be an episode of 10 treatments, episode of 15 treatments. Similarly for OBGYN, there will be an episode of like a pregnant lady has to visit from the day the pregnancy is detected to the day of delivery, right? That one circle like from treatment, that one circle is known as one episode. Okay, so yeah, this is the episodic, and the reason why CMS 1500 is not used for this is because uh for treatment cycles there are some other codes like occurrence codes and value code information provider have to submit. That's why, and those CMS 1500 currently do not support those type of codes. Okay, so this is why we use UB04, and due to UB04, we use 837I as an electronic claim format. Okay. Uh, uh, any questions?
Yeah, but I'm not sure if you explained this, but if not explained, then question for you. If it is explained, then question for team. What is X12 it used in EDI? You will hear this term more often, and you probably have read this term often. So what is X12 EDI transaction set? Have you read this? Anybody?
Yes, Abhinav. Yes, Nilesh. Yesterday in the X12 EDA, it was having 100 for the insurance plan description, 101 name and address list associate. It's in a standard from the American association.
Yes.
Yeah.
So these are the sets of the codes, whatever Abhinav explained, 270, 271, 837, 835. There are other EDI transaction like 997, 999, 277. There are multiple numbers. These are sets. These set of EDI is called as X12. I'm not sure. Abhinav may be correct. Are these set of 12? That's why it is called X12.
No, X12 is a standard agency.
Yeah,
There are
okay.
more than, yeah.
Okay. So you'll hear that term often, X12. So I thought let you know. Thanks there.
Okay, guys. So if no one have any more questions, I think we can close for now.
What is UB04, sir?
UB04 is a paper claim format. We submit against 837I. So if the patient is if the treatment type is inpatient or hospital or episodic, and the payer do not support electronic claims or EDI, payer do not have an interface for EDI claims. Okay, in that case, we submit UB04. UB04 is basically a paper. Let me show you if I have an example. UB04.
No, I attached in that chat. It is there. Abhinav, 2 days
Okay.
before it.
Yeah, so
Yeah.
when Avinav is telling about the paper claim and electronic claim, so electronic claim, as he mentioned that with the interface with the clearinghouse, or if the system is able to capture the external codes, it will go as a electronic claim, EDI claims to the insurance company. And this is that UB04 paper claim. That means it will come as a kind of fax. So from the mail room, it will get OCR scan will happen, and then it will get submitted as a fax to the payer along with the claim details. So then based on this, the insurance company will process the claim, because this particular claim in the provider or the biller, they couldn't submit electronically to the insurance company. So that is the basic difference between paper claim and EDI claims.
Okay, sir. Thank you.
Okay. Anyone have any more questions? Yes, please ask questions. Like, see, healthcare is very broad. There's like there are lots of things. Lots of things. Yes. Yeah. This is medical claim. This is CMS 1500.
So I will advise when we'll go with the US healthcare uh, claims and the different terminologies that are being used in US healthcare. So if it is a hospital or as you are telling that this is medical claim, so don't think that this is medical and you have considered all the professional claims in that medical claim is both UB and CMS. This is for professional, as Avinav has mentioned, that 837I, 837P, the same way this is called professional claims, and UB04 is called institutional or facility or hospital claims, but both are under the medical plan coverage. So do not think that medical claim is only for the professional. Okay, go with the terminology, then it will be easier for you to get involved in the US healthcare terminologies. Otherwise, in different times you will get confused. Yeah, no problem. Yes, that's the reason Avinav is stressing that you guys should come out with questions, because you may not get this kind of sessions in future when you will get a lot of work to do. So now, if you are, doing your homework nicely, then it will be easier for you to deliver the work as expected.
Attach both the forms again for the team. If you have any doubt, you can ask in the further question.
Yeah, sure.
Thank you very much, Abhinav.
And guys, this is one good blog. Actually, I used to follow this blog a lot. If you want to like deep dive into things, I'm just sharing link. Deep dive into things, like even you will get multiple things here. This is one good blog. I would request you go to this, like give 1 hour for some time, 1 hour daily for some time. Here also you will get a lot of information.
Okay, Abhinav, can you post that? Okay, already done that. Thank you. So thank you, team. We will probably have the second session around 1 today. But if you have any questions, you can reach out to Abhinav, so me in that order. We can actually, we'd love to see more questions coming from you and answer that. Thank you very much, Abhinav, so to be part of this. Thank you.
Thank you, everyone. Thank you, Avinav.
Thank you, Abhinav. Thank you, everyone. Thank you, Nilesh.
Bye,
Thank you so much.
everyone. We'll connect at
Thank
one.
you, everyone.
Thank you.
Thank you, everyone.
Thank you, everyone.
Thank you.
Thank you.
Thanks, everyone.